Hello and welcome to the June 8th Virginia Opioid Abatement Authority Abatement Academy. My name is Jennifer Nelson, Virginia Institute of Government, Assistant Director for Membership and Engagement. The Virginia Institute of Government is the leadership development and community engagement arm of the Weldon Cooper Center for Public Service at the University of Virginia. Through our research, leadership development programs, and local government engagement initiatives, we continue to work towards our vision of good governance, equity, and resilience in every Virginia community. VIG offers leadership development through SEI and LEAD, local government equity clinics, certification for treasurers and commissioners of the revenue, and customized training programs. State agencies and local governments can access a range of consultation and support services to build more resilient organizations. We have a team of seasoned public sector leaders and subject matter experts ready and available to facilitate boards of supervisors, city and town councils, leadership team strategic planning retreats, and other related events. Today, VIG is glad to partner with the Opioid Abatement Authority for the Abatement Academy series. This is presented every second and fourth Thursday through 2023. Here are a few housekeeping notes. This session will be recorded and posted to the Weldon Cooper Center for Public Services YouTube channel soon. If you have any questions, please type them in the chat and I will ask them for you. Thanks again for taking the time to join us today for this Abatement Academy session. Now, I am happy to turn things over to Cindy Newman, the authority's Abatement Resource Coordinator. Cindy?
Oh, thank you, Jennifer. I'm very pleased to be able to introduce our speakers today. We have Daniel Hunsucker and Tammy Bise. Daniel is the Population Health and Harm Reduction Coordinator for the Virginia Department of Health's LENOWISCO and Cumberland Plateau Health Districts, and he has worked in public health for over 17 years. He works with community leaders, coalitions, and stakeholders to empower their communities by promoting inclusion of trauma-informed care practices, enhancing protective factors, and building resiliency. He has presented on a variety of topics and programs at trainings, workshops, and conferences for the Virginia Foundation for Healthy Youth, the Virginia Community Services Board Association, the Virginia Preparedness Academy, the Virginia Governor's Task Force on Prescription Drug and Heroin Abuse, the National Association of County and City Health Officials at the National Preparedness Conference, as well as CDC's National HIV Prevention Conference. Tammy Bise is the Comprehensive Harm Reduction Coordinator for the Virginia Department of Health Mount Rogers Health District. Tammy is also privileged to supervise the Aspire program, which I'm sure she'll talk more about in her presentation. It's a peer support program where she is fortunate to work alongside a wonderful peer support specialist, Crystal Glass. Tammy received her Bachelor's of Science in Psychology from Radford University and her Master's in Counseling and Human Development from Lindsey Wilson College. Prior to coming to VDH, she worked within the CSB system for 10 years, most recently as a crisis clinician and mandated pre-screener, while simultaneously working as a part-time outpatient therapist in a private practice. Tammy came on board to oversee the CHR program in July of 2020. Since that time, she has worked hard to maintain the needs of the program and bring awareness to the needs of the substance-using population. She has become a fierce advocate for change and regularly works with community partners to assist and host events that aim to amplify her program's advocacy. Tammy has truly found a passion in harm reduction and hopes to expand services throughout her region, along with the wonderful team at Mount Rogers Health District. And just as a side note, I'll add in, I've had the pleasure of working with both Tammy and Dan in the community. They're doing some amazing work in Southwest Virginia, and I'm truly happy to turn the presentation over to Dan and Tammy.
All right, good morning, everyone. Hope everyone's doing good. Just want to start off talking a little bit about our programs and where they're located. Both Tammy and I are located in Southwest Virginia. In fact, the picture on your screen is downtown Norton. If you've never been or you're not familiar, I invite you to come on down. It's absolutely beautiful in the summer and the fall, as you can well see. But I represent both the LENOWISCO and the Cumberland Plateau health districts, which are located in the far southwest portion of the state. And Tammy works right next door in Mount Rogers. So between the two of us, we pretty much cover from Wytheville all the way down to Lee County in Virginia. I'll turn this section over to Tammy.
Good morning, everybody, and thank you all for letting Dan and I come and talk about our programs and what they mean to us and the kind of work that we're doing in the community. I'm going to go ahead and say that I'm very sorry if A, I look disheveled today, and B, I am disheveled today because I'm currently getting over a stomach bug. So just bear with me if I do trail off or, have to run away from the computer. Just keep in mind, I'm doing my best to just kind of come here and talk about this. But I'm so excited and very, very fortunate to have this opportunity. So I'd like to kind of first, before I get to the slides, start talking about my experience and kind of what harm reduction means to me. From my bio, you can tell I come from a clinical background as a therapist, and I'm married to a therapist. So mental health is a huge part of our lives and very important to us. So coming to harm reduction, I will say at the very beginning, I was a little bit unsure of how I would feel working in the field, because it is a little different than your traditional treatment setting. Oh, thank you. But I have grown to love what I do, and it has probably been one of the most meaningful positions I've ever held. Coming into harm reduction, that first time that you're working with an individual in active use and you realize that they're really nowhere close to wanting to quit in that moment. It is different than, when you're presented with individuals that are ready for change and need your help because they've came to you. However, what I have found is that it is the most maybe realistic approach I've ever taken. And we really meet people where they are versus where we want them to be, or what we want to see them in life. We talk to them about their lives, where they're at and where they want to go, regardless of whether that includes abstinence-based recovery or not. Along with that, I will just quickly talk about our Aspire program. When I first came onto the health department, we had a peer support specialist working in our program for CHR, but we didn't have that separate space for individuals to go to and talk with a peer specialist outside of our exchange room. I felt that it was very important to have that because I know the amazing work that peer specialists can do. And sometimes being in that environment is triggering if you are wanting to get into recovery or just minimize your exposure to harm reduction or anything that deals with using substances. So I was lucky to have a former employee that came on board, and he had a lot of experience in developing a program. So he came on and he helped me develop Aspire. He's no longer with us, but we have Crystal Glass who works our program, and she also helps me out in CHR as well. And she's amazing. So the program that we have for comprehensive harm reduction goes far beyond just even the public health approach, which is your basic fundamental approach to working with individuals at the health department in harm reduction. But we really focus on way more than that, their mental health, their well-being, and all around what we can help them provide, even if that's just basic needs. So I'll get into the slide now. What is harm reduction? Again, we meet people where they are. And we do take that more pragmatic and compassionate approach to public health, and recognizing that some behaviors may be difficult or impossible to eliminate entirely. And again, that is just the reality. That's always been the reality with individuals that use substances. And I think that it's more of a societal movement that needs to happen for us to really kind of understand that there is some people that do have circumstances in their life that it is going to be almost impossible for them to put it down 100% and walk away, or not have that assistance to help them, just kind of get through the day. So we're big advocates for MAT services and things like that as well, because those do help people really stabilize and find their space in the world where they can contribute to society, they can contribute to their families, and they can do wonderful things. But it's not necessarily your abstinence-based approach. So that is just a little brief summary of kind of what we do. And Dan, if you want to go on to the next slide. What we can do is also, beyond just helping people with their mental health and all that, we do prevent HIV and various types of hepatitis. We also try to reduce the risk of sexually transmitted infections by giving out condoms and doing education around safe sexual behaviors. We can reduce the fatal overdoses by providing revive training and naloxone distribution. We increase entry into the drug treatment world by doing referrals and just kind of helping individuals navigate what type of treatment is best for them, whether that's going into a rehabilitation facility or just doing something that might be more outpatient or least restrictive. So we also facilitate the referrals and linkages to other things, kind of case management type of services by, referring them to housing or insurance, getting them signed up for insurance, that sort of thing. We do reduce the needle stick injuries to first responders. And I will say we're very fortunate in Smith County, Virginia, to have Sheriff Chip Schuler be a huge advocate for us. I believe it was before I came on board, but I believe he actually had our very first letter of support in before we even asked him for it, because he understands that you can't just arrest this issue off the street. You have to approach it in a completely different way. So I'm just very fortunate to be able to work alongside him in the community. And he has himself, he will speak and say, they have definitely noticed a major reduction in any of the needle stick injuries that they previously had been, experiencing in the past. So that is really good. And we also remove the syringes from circulation and inappropriate disposal. So that is a big, huge focus for us in public health, is just reducing and eliminating that harm as much as possible. So we do dispose of syringes appropriately, and we do require that individuals bring back their supplies so that we can do that. We provide testing and treatment referrals. Our testing numbers for our program, and I'm sure a few other programs, they were a little bit wishy-washy there during COVID, because us at the health department, for one, we were a little swamped, if you can only imagine, and our nursing staff was very maxed out. So, but we have, since COVID has sort of eased off, we have been picking up those numbers, and we're looking forward to continuing to do that so we can show just how effective these programs can be in our community. And we, so we also reduce occurrences of endocarditis and abscesses. We do have individuals that come in and will experience abscesses from time to time, and we go over like safe use steps and how you do that to avoid those issues, because it can lead to very costly conditions otherwise. So, and Dan, on to the next. What harm reduction does not do, I wanted to cover that too. So CHR does not increase drug use or create new injectors. It does not increase crime rates, does not increase discarded needles in public settings, and we do not give individuals permission to use illegal drugs. Individuals that do use substances, they were doing so before they came to us to get harm reduction services. They will also tell you that we certainly by no means have increased their usage. We've just helped them make their usage a little bit safer so they don't have to reuse a needle repetitively. And later on in the presentation, Dan will show you a little bit about what a syringe can look like if you do repeatedly use one, and hence the abscesses that can occur. So we really try to work on reducing those risks and those episodes of endocarditis and abscesses, etc. On to the next. And I briefly wanted to talk about ACEs. I don't know who all here might be familiar with what adverse childhood experiences or ACE scores are, but I felt like it was very important to include this in our presentation, mostly because the vast majority, if not all, to be truthful, of our participants have relatively high ACE scores. If you get into learning a little bit more about this, and I'm fortunate I was able to get a master training from Dr. Anda, who was the lead investigator for the adverse childhood experience study. And so I learned a whole lot about it and a whole lot about how childhood adversity and trauma can completely rewire your brain, which also makes you more susceptible to making harmful
Pastor.
decisions.
Hey, yeah, come on in. You come in. Oh,
So
sorry.
I wanted to kind of include this slide, and y'all are more than welcome to go back and read over this. I won't read it verbatim and kill you with this PowerPoint, but I did just quickly want to touch on what that is. So the higher the ACE score that you could have, or the more childhood traumatic experiences essentially that you could have, is going to increase your likelihood of developing a chronic health condition. There's various types of conditions that they have linked to adverse childhood experiences. So it's incredibly important. And I would almost go to say that the drug use issue and the opioid epidemic, this would be the root cause of that. That is my personal opinion, but I also think there's a ton of science to back it up as well. So ACEs are very costly, as you can imagine, with all the conditions that it can lead to, what that can look like for our country and just our general ability to afford these conditions. It doesn't look good. So a 10% reduction in ACE scores could save us $56 billion. Again, a 10% reduction in traumatic childhood experiences could save our country $56 billion. That includes so many different types of conditions and outcomes that can come from that, including substance use and IV injection. So I just wanted to make sure that I did echo that and share that little bit of information because I think it says a lot. So, and then Dan, I'll hand it over to you.
Thank you. So as we were going through this presentation, Tammy and I really wanted to kind of talk about what harm reduction is, and especially those of you who are from the locality or may not be as familiar with public health. We really wanted to give you some information and some tools on how to talk about harm reduction. And it's one of those programs that, you know, sometimes can be a little bit controversial. So what I want to do is kind of talk a little bit about why it's important and some of those issues that typically comes up when you're addressing harm reduction with community members, boards of supervisors that may give them pause. When we talk about harm reduction, we talk a little bit about a small place called Scott County, Indiana. And this is a place that is slightly north of Louisville, and they're very rural. And a lot like Southwest Virginia, you know, their population was small. They had a lot of industry that unfortunately dried up in the area. It led to a lot of poverty. And like, again, Southwest Virginia, they had a lot of injection drug use in their community. Got a quick little video. Don't know if you'll be able to hear the sound or not. It might be a little low, but it's just background music. But it'll give you some important information about why Scott County, Indiana is so vital when we talk about comprehensive harm reduction. So, a lot of those images really look like something we could find here. And as you look at the picture of downtown Austin, Indiana, that pretty much looks like my hometown to me. The big thing when you're dealing with a community of this size, December 2014, their health department identified 3 cases of HIV. And, this is a place that in the last 5 years maybe had 1 case total. So when you have 3 cases pop up directly together, that's a huge red flag. By May of 2018, they had identified over 231 people that had HIV. And they were able to do tracing. All 231 cases were linked back to 1 single person in that community. And it spread from injection drug use primarily, having unprotected sex. So it all linked back to 1 person. And 91% of the 231 people with HIV also had hepatitis C. If you think about your own community, your county that you represent, if you were to take 231 cases of HIV and put in your county, how would that affect your county? What would that do to your healthcare system? Does your county have the specialists to be able to handle that? The infrastructure? When this happened in Indiana, it was a massive undertaking. And it led to a study by the CDC where they identified 220 counties that had similar risk factors. And in Virginia, there are 8 counties that made that list. Lee, Wise, Dickinson, Buchanan, Russell, Tazewell, Wythe, and Patrick County all made that list. They ranked them between 1 and 220 based on a lot of different factors. They looked at injection drug use, of course. They looked at rates of hepatitis B and C. They looked at poverty. They looked at the community and what the structure was like in the community. I do have the link to that assessment on the bottom of this slide. We will share these slides out, so anything that's linked, anything we talk about, you guys will have access to, so don't try to frantically write anything down. We will send this out for you. In July of 2017, syringe exchange became legal in Virginia. This has changed. They initially identified 55 localities in Virginia where they would like to see programs. And I come from Wise County, and we were actually the first program in the state to start up. It was a little bit of a fight at times to get it going. It took a lot of work. It took a lot of community work. And I kind of want to go over everything that went into it. So those of you who are thinking about starting a program in your community, you can kind of see some of the things that we did that you might like to replicate, to reach out to your community, to provide some education, to connect with your board of supervisors and county leaders and other key stakeholders that really might help make up their decision a little bit. When we talk about harm reduction, a lot of people hear needles and that's where they shut down. Tammy talked a lot about a lot of the referrals, a lot of the services, and a lot of things that go into a comprehensive harm reduction program. It's more than just giving out syringes and needles to people and taking them back. It's building a relationship. It's really focusing on the health and welfare of that person, really focusing on their total wellness. And, a lot of times with addiction, people become very isolated. They become very jaded. They feel like they don't have any resources anywhere they can go reach out for help. I think that's where these programs excel, is that it does build relationships, people who feel like they have no resources or no help. You talk about bloodborne pathogens. So harm reduction programs are disease prevention programs. They are not drug prevention programs. They are designed to prevent the spread of HIV and hepatitis. And we give out the supplies we do is because when people use anything that comes into contact with a person's blood has the potential to spread that disease. Sharing syringes, or even they're sharing rinse water, they're sharing whatever drugs in, whatever they're using as a tourniquet. If any of that comes in contact with blood and it goes on someone else, it has that potential to spread disease. And you may not think it would be a significant issue, but hepatitis C can live inside of a syringe for about 3 months in the right conditions. So, you know, if you think someone who doesn't have a sterile syringe, how many times might that syringe be used and reused? Might it be shared? It's important to use a new syringe. You know, human skin is very, very tough. And when it goes into a vein, it's even tougher. So it damages the needle. So if you were to take a needle and look at it under a microscope, this is what you would see. This is a brand new, never used needle. And then the very first time you use that needle, if you look at it again, you're going to start to notice a little bit of damage. The tip starts to become blunt, and there start to be these little tears and folds of the needle. And the more you use that needle, the more blunted and the more tears that happen. And what happens is you have bacteria that lives on top of your skin. When you put the needle in your skin, that bacteria starts to accumulate in these little tears and folds in the needle. And when you're reusing the needle, you're pushing that back in bloodstream. So causes a lot of damage that way. That's how we get endocarditis and a lot of those infections. And then the blunted tip damages the skin a lot, especially if the person injects in the same site. And that's how we get these lovely infections that are essentially just
PSA warning, hope you don't have an easy queasy stomach.
Yes.
This is what I was talking about, folks. This is what it could.
Some of the arguments you will typically hear against syringe exchange, Tammy touched on a lot of these, so I'm not going to go over them too much in depth. But you know, a lot of people talk about the money. Where's the money coming from? At cost, treat hepatitis C or HIV, and you know, hepatitis C can be cured. It's still a little bit on the pricey side, but no cure for HIV. It requires lifelong treatment. So if you look at $50 million to treat Hep C and $117 million for HIV treatment, a 10-cent syringe starts to look a lot better when you're talking about money. You know, it does not increase crime. We talked a little bit about that. One of the primary concerns of law enforcement that we had when we started was that it would bring a lot of people into the area. It would bring people from outside the region in, because here was this program all of a sudden in an area that had never had one. That did not happen. 5 times more likely to enter a drug treatment program that are in a program. Again, because they've worked on and they've kind of built up that relationship, they're more likely to reach out and seek help when they feel that they're ready for it. You know, we collect syringes, dispose of them properly. We make sure that there aren't a lot of excess syringes pushed in the community. 66% decrease in enforcement and first responders. So, I mean, that's a really big thing. And of course, you know, the primary objective, you know, we see a decrease in HIV and hepatitis infections. A little bit more on the cost effectiveness. Lifetime cost of treating someone with HIV, hepatitis B and C. Hepatitis, of course, is a viral disease that really affects the liver. If not treated, it can require the person to have a liver transplant. So you can factor that cost in as well. Needle stick injuries to law enforcement, $4,500 per incident. Needle stick injuries to healthcare providers, your first responder. Some require PEP, which is a medication that helps HIV if someone's exposed. So that's, you know, $4,500 per incident. About $6,000 per case if someone overdoses and has to go to the hospital. An abscess, you know, about $2,000 per case. Again, you balance that out, you know, 7 cents to 10 cents for a syringe. That's pennies. So, came across this quote in a meeting I attended yesterday, and you know, it really kind of stuck with me. You know, again, we really want to meet people where they're at. We want to provide them a welcome case. A lot of people that come into our program, the very first visit, they absolutely break down in tears because it's been so long since someone's treated them with kindness and respect and dignity, and they're overwhelmed. They've forgotten what it's like to be treated as a human being by a professional when they go looking for help. We started our work before syringe exchange was actually legal, and we partnered with NACHO and the CDC Division of Viral Hepatitis, and they reached out to us because we, of course, were on that list of the 220 counties that the CDC put out, and they said, what if that were to happen in our community? How would we deal with it? So the first leg of our project, we took a look at what happened if we had an outbreak as a result of opioid abuse in our community. We looked at a lot of different factors in and Cumberland Plateau Health District. So these are our rates of acute and chronic hepatitis B and hepatitis C. I did not include data from 2020 and 2021 because, as Tammy said, the data is a little bit skewed on the. We were testing for COVID. We were not testing for hepatitis unless someone had a significant liver issue or something like that. So the numbers are a little bit off. But if you look at our rates here, an acute case means a case that was 6 months, they've had it 6 months or less. A chronic case means they've had it 6 months or more. They are state rates in each of those. We did a tabletop exercise, and we wanted to look at what it takes on to one of these outbreaks. We partnered with over 50 responders, police, social services, our faith-based community. When this happened in Scott County, Indiana, they actually had to set up what they called one-stop shops in churches in their community. People could come, DSS was there, they could get their birth certificates because, you know, a lot of them didn't have insurance. So they needed those items to be able to sign up for insurance while there, to be able to get tested. So we wanted to take a look at how would this look in our community. When we conducted the exercise, we walked through everything, we developed it, pushed out preliminary plan meetings where we presented it, discussed it with community members, community leaders, and did that around the county. And we got feedback on like really was a good way to raise awareness in our community, what could happen. And then the final plan was actually written up by NACHO, and it contains 3 phases. We looked at community prevention, response, and community recovery. So again, you know, a lot of them, especially if you're dealing with HIV, is a lifelong disease. So, you know, it does require kind of a new normal recovery of back to the way things were. We finished that. NACHO was very pleased. So we actually got through the project, and phase 2 came about once syringe exchange was legal in Virginia. And phase 2 was really made to build us up and to start a syringe exchange. So we did several activities. We actually partnered with our local community coalitions, particularly ASAC, the Appalachian Substance Abuse for Prevention, Treatment, and Recovery. And they really championed reduction efforts in Southwest Virginia. We really wanted to take a look at an existing site. So we took a field trip up with some of our community, went to a program in Charleston, West Virginia to see how they operated. And then we really wanted to reach out to the community at large and kind of educate them on harm reduction practices and the issue and the need and what. We did that through a play called There's actually a group called Higher Grounds over in Kentucky that wrote and produced this play, and we were able, with our grant, to bring them over, and we did 2 performances, one in Wise and one in Clintwood. And the play basically was about a mother who had a daughter, and the daughter was an injection drug user. The daughter got hepatitis C, and the daughter died. So the mother didn't want this happening to another family, so she set out to start up an underground syringe exchange. She would go to her friends who were diabetic, and she would get a needle or two, one and a needle or two from that one, and pass them out of a little needle. Really touched home. We really wanted to tap into kind of our Appalachian roots of telling and music, and I think this really resonated with many members. At the end of the performance, we did kind of a panel discussion on reduction and hepatitis, and I really think it was beneficial in opening a lot of eyes. A little bit about our program in particular in LENOWISCO. So we are structured as a 1-for-1 program. So what people bring into the program as far as sharps, they get back. We do a maximum of 30 syringes per week. One of the good things about harm reduction is that you can really work with your community, and you can structure the program in a lot of different ways. Some programs don't have a maximum. Some programs are what they call needs-based, where they give a lot of syringes to the person. We really liked the idea of having accountability and having the person come into the program on a regular basis so that they got that relationship. They started to build trust with us. They got regular contact for testing, for treatment if they needed it, to help with referrals to any issues that were happening in their life. We do run a 96% return rate on our program. We've given out over, almost 1,800 doses of Narcan. Our people have saved almost 430 lives from overdose. We've done 757 hepatitis C tests, 762 HIV tests. We've gotten 165 people into treatment for HCV, 92% their very first time being linked to treatment. And those who have come into our program, been treated for hepatitis C and been cleared, have not been reinfected. So we have a very happy 0% reinfection rate. We do have a certified peer recovery coach that meets with our people when they come in. We've got 26 people enrolled in MAT, which means they're off of the heroin, the meth, the more dangerous, risky street drugs that they don't know what are, and they're working an MAT program. And 37 participants have withdrawn from the program because they completely stopped using. I'll let Tammy talk a little bit about the Mount Rogers program.
Yeah, so, and admittedly, I don't have all of my statistics. I was actually in the middle of pulling all of that yesterday when I had to leave immediately and go home from being sick. So I apologize for not having all of our stats, but some of what we do have, and again, we have been, it was December 2018 when the program began. We did not get our first participant until January 2019. As of now, we are looking around 472 participants, many of which do come from the Smith County location. And again, I was looking to run the rates for that, but didn't get to it. But from experience and knowing what I do have, it is vastly accumulated from Smith County participants. So that alone tells me that we're not reaching everybody that we should. If most of my folks come from one county when we cover 8, I'm not getting to all of the individuals that we need to get to. Our average age is 38 approximately. We do have some individuals that are older and have been using for a very long time. Then we unfortunately do have some that are barely into adulthood. Total visits, we have 3,895 total visits, unstably housed, and that includes individuals that are fully homeless or individuals that are living with friends. We included that stat in the unstably housed just because even if you're living with a friend, I don't really feel like that's always the most stable housing situation. having insurance, we have 86% of people that have insurance, which that rate is a little bit off. Again, I was trying to run it to get oh, here's a question that just came in. I'd like to go ahead and answer. What is the age of the oldest individual you ever serviced? If I had to guess, I believe it would be probably upper 60s.
Yeah,
I have
69 in LENOWISCO.
Yeah, we're right around there as well. And that those individuals that are in that age range, they've been using for quite some time. So I'm not, ultimately, abstinence-based recovery is not necessarily what they're going for after this lifelong addiction that they've dealt with, but they are at least coming to our program and doing it in the most safe way that they've ever done it. So we have also, you can look at some of our stats here, but we have had 308 reversals from our participants by using Narcan. We've gotten out over 2,000 doses of Narcan to our individuals. Our program in Mount Rogers, because Dan gave a little backstory of the LENOWISCO, we were the third site to come on for the state of Virginia. And I should have just roped Cindy Newman into this whole presentation with us, because she actually was the first original coordinator for the program. So I kind of took the torch from her, and she could speak a little bit better to how it all got going. But Dr. Shelton, our current state health commissioner, and Brianne Forbes Hubbard, our former population health manager, were really instrumental in getting this program to our area. So I will always be very grateful for the work that they did to bring it here to us. So, and we're continuing to try to run with the torch and get services out there to people that need it and reduce the stigma. I will say, before I turn this back over to Dan, and he may touch on this a little bit, our biggest issue in comprehensive harm reduction and expansion and getting the needs of individuals will always probably fall back on stigma, unfortunately. And that's something that we work really hard to try to provide some education and awareness around. We've brought some speakers to our communities to talk about stigma reduction. And unfortunately, like Dan said, it is far too often, I'm talking multiple times a week, that I have an individual that cries and breaks down with us about how they can't even get proper health care, because the moment that they walk into anywhere, emergency rooms, urgent cares, to get assistance, they're immediately discarded, or that's how they feel. And coming from the clinical background and being a former pre-screener in the emergency room evaluating individuals, I can say that I've witnessed it, and it is really it's discouraging, and it's sad, because at the end of the day, these are individuals, these are our family members, these are our sons, daughters, cousins, and everyone. So I wanted to make sure I touched base on that and how important it is to really consider having a program like this in your community, especially if your community has this increased risk of infectious disease. And yeah, that's all. Go on, Dan.
And these programs are really great at addressing stigma and connecting with people. And the opposite of addiction is not sobriety, it's human connection, and building that relationship and having people that they can rebuild trust with out when they're ready for help, as I've said. These are the current syringe exchanges in Virginia. So the LENOWISCO program has a site out of the Wise County Health Department, and then we operate a full unit out of Duffield, Virginia, IT clinic. See this list grow in the next months. I really encourage you on here from a locality, syringe service program in your district, in your county, that you reach out. Even if it's not ability, just being able to provide some support and show some compassion, that we hear you and we know the work really goes a long way. I do have some resources on here. As I said, we will lay it out to you guys. So this is kind of a list of resources and guides and lists of best practices and a link to the VDH main site and some toolkits and stuff. If you're interested in starting a program in your community, if you're interested in doing any of the work we did with like the tabletop exercise, there are some tools and resources on this list that can help you facilitate that. And you can reach out to Tammy or me anytime. Contact information. We'd be happy to take any questions anybody has.
Thank you so much, Dan and Tammy, for sharing about the good works you folks are doing in Southwest Virginia. So helpful and gives us ideas for how we can move forward with our own programs and how we can best use our Abatement Authority funding. Thanks again. Wanted to let people know if you have questions, please enter them in the chat. And I did have one question for Tammy about the statistics from Mount Rogers. Wondering if these are from the current year beginning in January or if they're fiscal year numbers.
So they're actually total from December of 2018 to now is what I ran for that. But I did want to kind of touch base. Our return rate has increased significantly. I typically do look at around a 91% return rate for our program. But again, sorry, I did not get all of the rates the way I wanted them before I got on here. But yeah, and if anybody has any questions, I'm more than happy to share some more information about our program.
That's great. Here's another question. When a participant states that they're ready to go into treatment, either MAT or abstinence, how quickly can you get that person into treatment? Also, what are the treatment facilities what treatment facilities are available?
I'll go ahead and answer that. So typically we can get individuals into services rather quickly. If it's MAT services, we at Mount Rogers Health District, we plan on partnering with New Day Recovery, which is an MAT clinic in Saltville, Virginia, hoping to do that soon. And they are pretty good about taking individuals in pretty quickly. Also, Mount Rogers Community Service Board, they have a kind of a rapid walk-in situation where if a person needs assistance, we can send them on and usually get them on pretty quickly with services. When it comes to a rehabilitation type of facility, something that's a little bit more in-depth or long-term, I will say we struggle with that significantly in Southwest Virginia. There are programs that are in the works, hopefully, to come on and be able to take in individuals to live in a rehabilitation facility type situation for a while, but currently we have maybe two in a decent range of where I'm at in Marion, Virginia. So that is a little bit of a wrench that gets thrown in when a person needs to go away, which many people do.
Yeah, in our Scott County location, so we actually take our mobile unit and we park it in the parking lot of Revita Health, which is an MAT provider. So that's just a short walk across the parking lot. Even just go over to the doctor who's over that practice and kind of see what it's about, step in the right direction. Community Services Board in our area is for health. They have a crisis team that we kind of facilitate getting them in. But then also, if they do need something like that, it does take a little bit of time and coordination. With harm reduction, time of the essence, and when that person's ready to go, you have to really work hard and work fast to get them in as soon as possible. Because if they have time to think about it, they'll talk themselves out of it. But if you can keep the ball rolling, then they're more likely to go.
That's great. Thank you for sharing that. I'm going to put into the chat the page on the Opioid Abatement Authority's website, which contains all of the information about past opioid abatement academy sessions, including any handouts that were included. When we have this video ready of this session will be on there, as well as the PowerPoint presentation from Dan and Tammy. Here's if there's any other questions, we'd love to address those. But otherwise, people are just very grateful for the information that you both have shared and the good works that you're doing. So I want to thank everybody, and there are several opioid abatement academy sessions left in 2023. The second and fourth Thursday of every month through the rest of the year. Please join us, and we'll get that information out to you. Thank you again, Dan and Tammy. Thank you, Cindy, for joining us today as well. Thank you, everyone.